With a glow of the screen and a heart full of pride, he's talking with experts from the world far and wide, broadcasting his voice through the good and the grand on YouTube, Facebook, LinkedIn, and X across the land. Every Saturday morning, he's the urology man.
Hey, good morning, everyone. I'm Vic Senese. Welcome to UroNurse. I'm coming to you from Florida today. I got away from all that Chicago cold weather and coming down here to spend the holidays. So I'll be coming to you from Florida for the next few weeks. So if things look a little fuzzier because of that, I don't have my super high speed internet and all the other niceties of life, but we'll get by just fine. Hey, if this is your first time checking us out, be sure to check out our website at uronurse.com. Best place to learn more about the show, see our previous episodes. Also, we have an audio podcast. If you want to listen to something on your way to work, go ahead and listen to the past episodes on our audio podcast through Apple Podcasts, Spotify, iHeart, Amazon, and of course, YouTube Music. All those are available. So this week, we've got a great show for you today. Today on UroNurse, we're joined by a true leader in advanced urologic care, Alex Hughes, lead nurse practitioner at the Austin Urology Institute. He brings extensive expertise in men's health and minimally invasive BPH treatment. Alex has been at the forefront of innovative approaches to benign prostatic hyperplasia, working closely with patients through every step of their treatment journey. In this episode, Alex will break down Aquablation therapy, a next-generation robotically controlled heat-free waterjet treatment designed to precisely remove prostate tissue while preserving sexual and urinary function. He'll share real-world insights, discuss ideal candidates, and explain why aquablation is rapidly becoming a preferred option for many men struggling with BPH. So please help me in welcoming Alex Hughes to UroNurse as we explore how aquablation is reshaping prostate cancer. Alex, welcome to the show.
Thanks, Vic. Thanks for having me.
Yeah.
Well, hello, everybody. Vic did a very good job of introducing me, but my name is Alex Hughes. I am from Austin, Texas. I've been in urology for about 7 years. I work at the Austin Urology Institute. I've worked myself up to the lead nurse practitioner, meaning I have some NPs and PAs that are below me, where I've also trained them on how to do diagnostic workups for BPH patients. One of the biggest revolutionary therapies that we've had is aquablation therapy. It's been a huge success for our practice and for our patients alike. So that's what we'll be talking about today, Vic.
All right. Well, let me just bring your slides up and I'll let you get rolling right now. You're good. Take it away.
All right. Thank you, Vic. All right. So again, this is my slide deck for consulting patients for aquablation therapy. This is primarily geared towards the NPs, the PAs, the medical assistants, the surgery schedulers, and the surgeons. So anybody that's working in the practice that, speaks to patients and speaks to them about BPH therapy. So I'll go into detail about the ideal candidates for aquablation therapy and why I like this therapy and all the other therapies over medications. So this is one of my disclosures. I am a PROCEPT biorobotics consultant. So I do side gig for aquablation therapy. So I do presentations and I teach other clinics on how to talk to patients on aquablation therapy, patient selection. And I teach nurse practitioners and physician assistants on how to properly diagnose these BPH patients and sign them up for the right surgeries. This is a little bit about myself. The beginning of my career, I was a firefighter, paramedic. I really got attracted to the medical side of that. So I went into my nursing career. I was an ICU nurse for quite some time and got my nurse practitioner degree. I worked myself up into the lead position at Austin Urology Institute. So I train all of the other APPs and PAs that we hire, and I train them on how to do diagnostics. I train them how to do cystoscopies, transrectal ultrasounds, and some other advanced procedures. I also have satellite clinics. So Austin is my home hub clinic, and then we have Dripping Springs in Georgetown, which is about 20 miles outside of Austin. And I have disposable cystoscopies. I have a portable transrectal ultrasound. I have urine flow measurement devices where I can do all of these workups outside of the hub of the city and bring the patients in to have the actual surgery in Austin, where my surgeon works. I do this also. We do telemedicine as well. So I can do the entire workups, keep them in their home base, review everything, and then bring them in for their surgery. So my whole goal here is really to get patients off of medications, so de-prescribe BPH medications and get men into an effective, durable treatment that preserves their long-term health. The primary reason Aquablation has exploded in the market is really based on Teleflex's product UroLift. So UroLift came out and was a minimally invasive surgery technique to open up the prostate, and it guaranteed, no sexual dysfunction, no erection problems, no ejaculatory issues, and no stress urinary incontinence. But the issue, if there is one, and we use UroLift all the time in our clinic, is the longevity of it. So it only get the patient about 3 to 5 years of longevity, sometimes 7 years on the long end. So Aquablation and Procep have really seen how much men cared about their sexual function. They cared about their ejaculatory function. They've always cared about stress urinary incontinence, but these sexual function, effects were really important to these guys, and guys were living longer. So, the guys are living more into their 80s and 90s, and they're actually being sexually active into their 80s and 90s. So they needed something that would be a more of a long-term solution, or like a resection procedure that would also offer those same kind of promises. So that's where Procep and Aquablation really shine. So the current state of BPH population that are, we're seeing in our practice, 34%, this is older data, this is from 2021, but 34%, so 4.3 million patients are watchful waiting. They're coming into your practice. Yes, they're waking up in the middle of the night. Maybe they have a weak stream. Yes, they're straining, but they don't want to do anything. They don't want medical therapy. They definitely do not want a surgery procedure. But 64% are on some form of medical therapy. Either that's your alpha blockers or your 5-alpha reductase. So that's your tamsulosin, your alfuzosin, your finasteride, your dutastarides. And only 2% are moving forward with a surgery procedure. So that's only 248,000 patients out of 10 million patients are actually moving forward to something that actually treats the mechanical problem. So I always tell my patients, and when I do these webinars and I'm telling the other clinical practices that how to do this, you need a mechanical solution for a mechanical problem. Medications are a Band-Aid for this issue. I have scoped so many patients, and when I say scope, I mean cystoscopy, where they've been on dual therapy with an alpha blocker or a 5-alpha reductase for 15 to 20 years, and you scope them, and their bladder looks so trabeculated, it looks like the surface of the moon. So that is permanent bladder damage. So the medicines are not doing the prostate and the patient justice. So we have to intervene somewhere in the middle here. I had another webinar fairly recently where I was countered that we just wait for the patient to say, hey, I want surgery before we start moving forward with a cystoscopy and transrectal ultrasound. My pushback to that is guys don't like to complain. They are only going to complain when it's like the world is ending or the end is near. So if you wait for your patient to say, hey, I need a surgery, excuse me, they're going to be coming in when they've already been on dual therapy for 10 years. Their IPSS score is going to be closer to a 30, and their PVRs are going to be 150 and above. That's too late to intervene. You want to intervene earlier on, and that's where my practice and how I teach shine. You want to catch these patients before it becomes a permanent bladder problem. So why do I run medications through the mud? Alpha blockers, side effects, orthostatic hypotension. It can worsen heart failure, and you can have retrograde ejaculation. Real world example, I had a 76-year-old male patient that came into my practice. I was being the good urology MP, and I saw him. His IPSS score was like a 20, and I said, hey, let's do a medication trial and see how you do. I put him on tamsulosin. 2 days later, I had an an ER physician call me overnight that my patient had gotten up in the middle of the night, had a syncopal episode, passed out, hit his head on the toilet, and had 17 staples across his forehead. So thank God, or luckily, he was not on blood thinners, or it could have been literally lights out for him. Now, that's rare, and I know that's rare, but it's just to say that these medications do have side effects. And as we get older, we're all going to end up, I mean, I know there's some lucky few, but we're all going to probably end up on some medication or another. You know, you're probably going to end up on a blood pressure medicine. You're probably going to end up on a statin. You're probably going to end up on X, Y, and Z. So if you have medicines that you can potentially treat with a surgery that you can get off of your profile and decrease polypharmacy, that's what should be going on. So another real life example, I had a patient, this was not too long ago, let's call it 8 months ago. He was on tamsulosin, finasteride, and oxybutynin. Those are 3 medications he's taking for BPH. That's 3 medicines a day, 3 medicines going through the liver and the kidney. That's 365 pills times 3 a year. And those all could be reduced with doing an aquablation or any of the BPH procedures. So our really goals for these patients should be medication reduction, especially when you have proven therapies and proven surgeries that are safe for these patients. 5-alpha reductase, this is your finasterides and your dutastarides. In my practice, my surgeon scared the bejesus out of me with these medicines. There's a cognitive decline, a potential side effect from them, erectile dysfunction, decreased libido, ejaculatory disorders, mood swings. Then there's a black box warning about the cognitive decline. You can also take this medicine for hair loss. So I was seeing younger and younger patients come into my practice taking this from, these online pharmacies for hair loss, complaining of, low libido, erection problems. This is one of the only medicines that I know of that has a post-finasteride syndrome label with it. So these are 2 medicines that, hey, a lot of the side effects are very rare, but if you can get the patients off of them and offer them something more permanent, that's what we should be doing with them. This is a quick video on aquablation therapy. I'll let it run.
The Hydros robotic system is the next generation AI-powered robotic platform that delivers aquablation therapy for benign prostatic hyperplasia. This clinically proven therapy uses real-time ultrasound guidance combined with cystoscopy to provide surgeons with a full detailed view of the anatomy. Developed from a library of real-world aquablation therapy procedures, First Assist AI identifies critical anatomy on ultrasound to aid the surgeon in designing a patient-specific treatment plan. Through robotic control, the heat-free waterjet precisely follows the treatment plan. During every procedure, prostate tissue is accurately removed in an efficient and predictable time frame. The streamlined workflow begins with the insertion of an ultrasound probe, providing the surgeon with a full view of the prostate. The single-use handpiece with integrated cystoscopy allows the surgeon to visualize the anatomy as it is inserted, positioned into the bladder, and docked to the articulating arm. Once the entire prostate is visualized, the surgeon initiates treatment planning. Treatment planning begins by identifying critical anatomy using First Assist AI to develop a plan specific to each patient. Adjustments to the plan can be made to the resection angles and depths under real-time ultrasound. The Verumontanum protection zone is created to help protect sexual function. Robotic-assisted resection removes the desired tissue and avoids the verumontanum by using a bilateral cut to help preserve ejaculatory function. The surgeon maintains control of the resection throughout the entire procedure. Once waterjet resection is complete, the surgeon performs focal bladder neck cautery using a resectoscope to cauterize exposed blood vessels at the bladder neck. The Hydros robotic system is the next generation AI-powered robotic platform for aquablation therapy, a clinically proven procedure that provides significant durable symptom relief while preserving sexual function and continence across prostates of all shapes and sizes.
So that's the video that I play for my patients. So like when I do their diagnostic cysto trust and I feel like they're an Aquablation candidate, I have that preloaded on my iPads or my wall boards in the clinic, and I have them watch it. The biggest difference between other resection procedures and this one is you have real-time imaging. So you have an ultrasound wand looking up at the prostate. All the other resection procedures is going solely on the surgeon's experience and tissue changes. So you would resect, and you would see like, okay, I feel like I've gotten enough. But when you have something, and the way that I kind of explain it to my patients is, if you have two battles that are going off in the 1500s, and you have the Northern Army going against the Southern Army, and one of the armies has a map of the entire land that the other army is having, they're doing their battle on. You're going to have a much more advantage if you have a map of the landscape. So having the map will actually give the surgeon more detailed view of where the issues are coming. So the issues, meaning the prostatic obstruction potentials. So the other reason why this is important is how fast the actual AquaBeam goes. So that AquaJet is resecting at a speed that's done in like 5 minutes. So it doesn't give the residual tissue from the prostate time to heat up. That's where they were having erection problems with other BPH procedures, is you would sit there and scoop out prostate for 45 minutes to an hour. The residual tissue around the prostate would heat up, and that's where the erection nerves are. So those are the two biggest technology advances. It's very fast. The procedures, whenever I sign a patient up for an aquablation, they're usually done, and we talk about in the OR. The OR time is about 45 minutes to 50 minutes, depending on the prostate size, which is very fast, meaning you're under anesthesia a lot less time as well. So optimizing BPH care plan with a team-centered approach. So basically what I mean by that is why my practice started utilizing APPs so much. So our practice was getting busier. We had more patients coming in. And it was a 6 to 8 week to wait to get in with my surgeon. So we were actually seeing patients, I don't want to say lose interest, but they got tired of waiting. So if you were going to get into Dr. Shaw for a new patient visit, it would be a 6 to 8 week long wait. And then to do a cystoscopy and transrectal ultrasound, it's another 8 week long wait. And so he was seeing patients starting to actually fall off of the schedule because of these wait times. So he came to me and said, Alex, you're doing great with your cystoscopy stent pools. You're doing great with your, cystoscopy Botox. How would you like to do some diagnostics? And I was very excited about that. So I was motivated to play a bigger role in the patient care. So how we did it is really through like a 6-month period. And I kind of pulled that one out of thin air, as I don't really know how long exactly it took. But me and Dr. Shaw shared schedules a lot of times. So anytime he had a cystoscopy and transrectal ultrasound, if I had time, I would just pop over there and watch him do it. And I probably watched him do it probably 10 to 12 times. And then he slowly kind of let me start driving the cystoscope, where literally I would get the cystoscope in my hand and he would put his arms around me and we would drive it through the patient. Transrectal ultrasound, it was easier to me. We were having me do some renal ultrasounds, checking for hydronephrosis, no advanced imaging. That was a little bit more complex. Whenever you're doing a transrectal ultrasound, it's really only one view. I mean, it's 2 views, it's sagittal and coronal, but you don't miss the organ system. It's very easy to find. When you're looking on the abdomen for a renal, the kidneys, it's harder to find. There's more stuff to get in the way. So the transrectal ultrasound was pretty easy to teach me. So we introduced that over really about a 3 to 4 month period. And then I would take pictures. So we have Athena as our charting system. So we have something called Athena Capture. So I would literally take pictures of the cystoscopy. I would take pictures of the prostate ultrasound. I would do both of those. But I would take pictures of the prostate obstruction. I would take pictures of the trabeculation. I would take pictures of the UOs. And I would take pictures of the retroflex. And then I would take pictures of the transrectal ultrasound, the sagittal and coronal view. This was great for the patient's chart and billing and continuity of care, but it also gave Dr. Shaw a chance to review all of my charts, especially if I was signing up patients for a potential procedure. Originally, I wasn't signing up for surgeries. I would do the workups, have them come back to see Dr. Shaw. He would make the decision on surgeries. What we saw over time is my recommendations for surgeries were exactly what Dr. Shaw would recommend. So slowly we started to introduce, okay, well, I'll just sign up patients for surgeries. Dr. Shaw will meet them on surgery day, and he would review the charts beforehand. And that's really kind of been our package. And so now I have other NPs and PAs where I've actually trained them on the exact way to do it. Now I review their charts and make sure that they are signing the patients up potentially for the correct surgeries. And we've had no adverse events utilizing that algorithm. I also have my patients look at all of their imaging. So when I'm doing a cystoscopy, I make them look at the median lobe or the trabeculations because I really feel that patients seeing is believing. After I do their workup, I'm spending a pretty good amount of time, 15 to 20 minutes talking to them about all of the options of surgeries. And I'm scooting them where I think they should go in terms of what surgery they would want, but I am giving them options. And I really believe that, if you draw out the PVRs and tell them why they're having the symptoms of nocturia and look at the anatomy, they can understand why surgery is the better approach. I also created a very clear BPH care plan pathway that helped me manage patients more efficiently and consistently, but it also helps me teach how up to other providers and other APPs on how to do this in a step-by-step approach. So when you don't have a clear BPH care plan pathway and a step-by-step approach, these are the things that can really go wrong. If you have auto refills for your medications, you have no reassessments, high risk of drop-off. And honestly, when you do auto refills on your medications, the prostate is going to continue to grow. So you're not going to see this trend line of a PVR going from a 70, PVR post-void residual, from a 70 to an 80 to a 90 to 100 to 110. You're not going to see the IPSS score go from 15, 18, 20 to 25. So you have to reassess these patients because their body does change. If you have low PVR monitoring, there's no objective data. It's delayed care. If you tell the patient, okay, hey, just call us if this doesn't work. If you start them on tamsulosin or alfuzosin, you're like, hey, just call us if you're not having any issues with it. They're not going to call. The patient's going to drop off. You've got to schedule a reassessment. And why that's important, on my algorithm, I'll tell you why. If you start a patient on alfuzosin and their IPSS score is a 22, we use the IPSS score a lot, and I'll kind of review with y'all in just a second. But if you don't bring them back in a month and you see that IPSS score go from a 22 to a 15, you don't know if BPH is actually their issue. They may need a cystoscopy to rule out a stricture, or maybe they're having overactive bladder or pelvic floor dysfunction. So you have to reassess these patients. And if you have no definitive surgical pathway, there's no standard evaluation. There's very few surgical consults. So the workup tools from basic to advanced. So these are the things that I say every urology practice that's going to be seeing BPH needs to have and set in stone. The first three are like, hey, this is standard. This is what every patient should get. IPSS sheet. This is a score from 0 to 35 relating to bladder health and prostate obstruction. But it is a numerical data set that you can sit there and see if your interventions are working for the patient. And you can see if they're actually having issues. Bladder ultrasound or a PVR machine, you have to be able to assess bladder health and retention. A urinalysis machine, you have to rule out if it's infection or not. Those are the three things that all of my BPH patients that are standard, that are coming into our practice. Maybe they're on alfuzosin or tamsulosin or finasteride, or they're just having new symptoms. That's what they're going to get on their initial visit. Some more advanced stuff. This is urine flow measurings, UroCuff. So this is a office-based urodynamics for males. And it checks their urine flow and abdominal activity and kind of gives you a understanding on if this is more overactive bladder versus a flow issue. Proud P, which I know you're going to have a webinar or on Uro patient after this about Proud P. But there's home-based monitoring. And then after all of that stuff that you've done for the patient, which honestly can be done in one visit or two visits, you can move them forward with advanced treatment options or diagnostic options, cystoscopy and transrectal ultrasound. So this is a little bit about Proud P. Again, Vic has told me that the Uro patient webinar is going to be coming on after this, and it's going to talk about Proud P a lot. But this is home-based audio monitoring for urine flows. I use it for a smorgasbord of different things now. I use it for pelvic floor physical therapy. I use it for overactive bladder. I use it for lots of different things. I use it for intake and output, for bladder diaries. So I utilize it a lot, and my patients have been highly successful with it. So this is my BPH care plan. So any patient that's coming to my office that is has BPH potentials. So basically, any male that's 50 or older that's coming into the clinic is going to get an IPSS score. That does not mean that they're going to go down the BPH algorithm here, but they're getting an IPSS score. I think of it almost like, those mundane forms you have to fill out at the doctor's office. It's almost a check the box thing, because men will not complain until there's an actual issue. So you want to catch these patients when their IPSS score is 10 to 20. Not when it's 25, not when it's 30 and they have a PVR of 400. You want to catch them early. So if they're coming in for urinary frequency, urgency, nocturia, weak stream, then they're going to go down this algorithm. But if they're just 50 and above, say they're coming in for kidney stones, say they're coming in for testosterone, say they're coming in for kidney cancer. If they're 50 and above, we give them an IPSS score. And the reason we do that, I've had many visits where it's been for low testosterone, and this patient has had this IPSS score, and they're scoring a 12, 13, 14, 15. And they weren't going to, complain about these issues. So I will do the visit, and my testosterone visit takes, 5-10 minutes on the long end. So I have 10 more minutes to discuss things with my patients. I will say, hey, I notice you're having some urinary symptoms. How long have you been having this? And do you want to kind of move forward with, kind of talking about this? Maybe you could give them a medication trial and bring them back in a month and then really start to reassess their BPH. I tell my patients in my clinics all the time, if you start talking about 2 different issues, you can bump this up from a 99213 visit to a 99214 visit. So you can actually increase your retention rate and your cost of your visits utilizing your IPSS score. Say your visit goes 5 minutes, then you can put the PVR on them. You could actually move forward with a BPH consult. So it's all about treating the patient and diagnosing the BPH. So they come in and they're here for nocturia and weak stream. IPSS score, PVR, UA, DRE. So if they're not on medications and their IPSS score is above 10, we give them 1 month trial of an alpha blocker, and we bring them back in. Repeat the IPSS, repeat the PVR, and you want to confirm that the alpha blocker is working for the patient. So if they had a PVR of 80 and their IPSS is 17, and you bring them back after a month, and their IPSS is now a 12 and their PVR is 90, those are check boxes both in the BPH category. You have confirmed BPH. So then I move forward with either Proud P or UroCuff, and then I look at their urine flow measurements, and maybe we could review that over telemedicine, and then I move them forward with cystoscopy and transrectal ultrasound. If they come into our practice and they're already on medications, which a lot of times we're a specialty practice, they're already on their meds. So I discuss the side effects of these medications. If they're on dual therapy, like finasteride and tamsulosin, I'm going to take them off finasteride first. I bring them back in 30 days, recheck their IPSS. If their IPSS score starts to increase, then I've confirmed BPH, and then I can move them forward with the urine flow test and then eventually cystoscopy and transrectal ultrasound. If there has no change, you can ongoing surveillance with those patients. So I've had many times where, their IPSS score will be a 10 on dual therapy. I take them off their finasteride, it stays 10. I take them off their tamsulosin, it stays 10. Maybe that patient, was misdiagnosed or mistreated, and they needed more overactive bladder medicines or pelvic floor physical therapy. So I think y'all probably see the theme here is I utilize my data to make an informed decision for the patient. And when you have your data in front of you, you and the patient can both sit there and say, okay, my IPSS was 30, now it's 20. My PVR was 200 and now it's 120. You can objectively see these changes, and then you can move forward with a potential procedure, and then you can see those changes even more after that. So after I do my cystoscopy and transrectal ultrasound, if the prostate is 30 grams or less, then it's a minimally invasive surgery technique. UroLift is the big winner at my practice, but UroLift and Resume are kind of the other ones, and I tend. 30 to 50 grams, I kind of say the world is your oyster. If I have a 40-gram prostate and my patient is, 52, and he was like, I do not want to go under anesthesia, then maybe that would be a good UroLift patient. If it's closer to 50 grams and they've already done a UroLift and they're like, I am not doing that again, and they are okay with going under anesthesia, that's a good Aquablation procedure. So 30 to 50 is kind of, the dealer's choice, I guess I should say. Anything above 50 grams is an Aquablation candidate. We do TURP. Very rarely we'll do a TURP. We utilize PAE as well, so prostatic arterial embolization. Some of the really big glands, we'll sometimes do a PAE first, decrease the size of the prostate gland, and then do an aqua later. This is a quick review of my BPH Therapan pathway.
Hello, everybody. My name is Alex Hughes. I'm the lead nurse practitioner out here at Austin, Texas, here at Austin Urology Institute. I'm going to walk you through our BPH care plan pathway. This is our clinic out here in Austin. This is the patient checking in with reception. This is where they can start giving their insurance cards, insurance verification, and driver's license. After he's been checked in, he will wait in our lobby where we do have BPH and urology reading material. The MA will call him back, walk him through, and the first stop is going to be to the bathroom. We do need a urine sample. The biggest reason is we want to see what his PVR is. So that's post-void residual. This is performed by a bladder scan. So after the patient leaves a urine specimen, we'll do a urinalysis on it to make sure that there's no urinary tract infection. The medical assistant has brought him back to the room. She's performing a bladder scan, as you can see in the video here. This scan takes no longer than 10 to 15 seconds and checks bladder dysfunction. So in our practice, anything above 100 needs to be evaluated. So this patient had around 200 PVR, which shows some severe bladder dysfunction. So the medical assistant will dictate it here on the chart, and then we'll give the patient an IPSS score. The IPSS score is the International Prostate Symptom Score. The scoring sheet is a score from 0 to 35. 0 to 8 is mild, 8 to around 20 is moderate. Anything above 20 is severe symptoms. This patient has checked off that he is severely symptomatic, which is why he is here. He's here for nocturia and dysuria in a weak stream. So taking him down the BPH care plan pathway is the right appropriate thing to do, especially with that PVR of 200. As the patient finishes his IPSS, he will give it to the medical assistant. At a later date, we may do a urocuff test. This is a urine flow measurement. It checks the mils per second on his urine flow. If the patient shows an obstructed urine flow, which he does, which we will review later, he needs a cystoscopy and a transrectal ultrasound. The cystoscopy is done by one of the providers, either APPs or the MD. It's a small bore camera that goes through the penis and looks at the obstruction of the prostate. It takes about 3 minutes, and then we'll need to do a transrectal ultrasound. The ultrasound takes about 2 to 3 minutes on the backside and takes an exact view of the prostate, and that's how we get the volume done. After this, the physician will have everything he needs to do to give the appropriate diagnosis. Very little discomfort, but it is worthwhile, and it does give us a lot of data. So here the provider has all of the information he needs. He has the IPSS score, which is severely symptomatic. He has the Uroflow study that shows obstructed flow. And he has a PVR that's above 200, which shows some severe symptoms. So we'll do a medication trial of alfuzosin or tamsulosin and bring the patient back. This patient's IPSS score has decreased, but it is not perfect, so we can confirm the diagnosis of BPH. The medication would not work if you did not have that diagnosis. So this is when I really start talking about Aquablation therapy and a surgical intervention. I review our wall boards and teach them about Aqua. After they've done the Aqua, we bring them back and do another IPSS score. As you can see, he's scoring a 1, all the way from severe down to mild, and he's extremely happy with the procedure. This is our BPH care plan pathway. Not every patient follows this exact way, but as you can see, the patient is extremely happy with his Aqua therapy. Thank you for listening. Hello, everybody.
So, that's kind of it in a nutshell, but, it's literally that simple. And you can see on that video, I think I did 3 IPSS scores. So we utilize the scoring system a ton because you have to have some kind of tangible numbers to see if your interventions are working. So the national surgical average is around 1 to 3%. At Austin Urology Institute, our conversion to surgery was 49% after we got them to cystoscopy and transrectal ultrasound. I just met with some higher ups, and they said usually after a diagnostic cystotrust, you're looking at around a 12 to 14% conversion rate. So something that we're doing at Austin Urology Institute is really resonating with these patients. And some things that we do is we don't scare patients about the cystoscopy and transrectal ultrasound. It is a 3 to 4 minute exam. Yes, it's uncomfortable. Yes, it's a scope going into the penis. Yes, it's an ultrasound going up the backside. But you have to do it so you can sign up the patient for the correct procedure. I compare it to a colonoscopy all the time. So colonoscopy, cystoscopy. Obviously a colonoscopy, you have the beautiful propofol whenever you're getting it done. But we do have nitrous oxide available. We use lidocaine jelly in the urethra. So we tell all these things to our patients to make them as comfortable as possible. I tell them all the time. I have done over 800 of these things now. So I'm gifted in it. I'm comfortable with it. I'm quick with it. I emphasize bladder health. There is no imaging procedure you can actually do to look at the trabeculations of the bladder. Now, on a pelvic MRI, you may see a giant bladder diverticulum, but that's too late. You need to do this whenever the trabeculations are like grade 1s and grade 2, so you can decrease that prostate obstruction and decrease the pressure in that bladder before they become a problem. Reiterate the importance of looking at the problems, strictures, and median lobes. Again, there used to be a VCUG imaging study that would look for strictures. We can't even get that ordered in Austin anymore. So the only way you can diagnose a stricture is by scoping the patient. A median lobe, I scoped a patient yesterday that had been on medications. He's like, my medicines aren't working. And, for someone that had not been scoped, maybe you would put them down the overactive bladder pathway. Maybe you'd put them down the pelvic floor pathway. But I scoped this patient, and he had a golf ball medium lobe that's sitting over his bladder outlet. So no wonder his medications weren't working, because where the medications work is in the prostatic urethra. So he had to have scope to see the problem. Use all of your data. When I sit down with my patient and I show them the IPSS score before and after meds, the PVRs before and after meds, the Eurocups, the Proud piece, I use all of that data to say, hey man, it's time for you to kind of move forward with the cystoscopy and transrectal ultrasound. And obviously, we're at 50%. So that's 1 out of 2 patients move forward. So I will scope healthy patients. And, it's kind of part of the patient selection process. And if they're healthy and their bladder looks good and they're, the BPH medications are working for them, I'm not going to hog tie them and say, you have to do surgery. But I just need all of the data so that we can all make an informed decision so that we're not missing something. So these are my analogies that I utilize for my patients. I kind of already hinted to this one, my mechanic analogy. So if you take your car to the mechanic and the mechanic's like, oh, I've seen this problem 1,000 times. Here, you just need a new spark plug. You need some new synthetic oil without looking at your car. That's us trying the medications. We're not actually looking at the issue and finding the issue and then using the medication to treat it. So getting under the hood and looking at the issue, looking to see if you actually need a spark plug or a new alternator or something along those lines, that's us getting under the hood and doing a cystoscopy and transrectal ultrasound. The clogged toilet, when I have a patient that has retention, I say, hey man, your toilet's clogged. And what happens when you have a clogged toilet? You'll try to use Drano. Drano is using medications. I don't know if y'all have used Big Drano's gonna be mad at me now, but if you use Drano, it works like 20% of the time, maybe 8% of the time. What you got to do in there, and we all know it, and we all love the process, get in there and plunge out the actual clog, or eventually got to snake out the clog. So that's where you utilize, hey, we need to do some bigger guns other than just doing medicines. We got to get in there and, clean out the clog by using a procedure. The rings of the tree. So this is when I scope my patient. I see the trabeculations in the bladder. I will actually talk about the rings of the tree. And if you cut a tree in half, you can see how old the tree is. How more severely trabeculated the bladder is how long they've been working through retention. Grade 1s, grade 2s, you've probably been having about 5 years to 10 years. Grade 3, you're looking at about 10 years plus of retention. That's where you're starting to see your PVRs in the 2s, 3s, 4s, 500s. Cleanup batter. So I tell all my patients, it makes no difference to me as the provider what procedure they choose. I have just seen the success from it. And I will say that, our call volume has gone down a tremendous amount since utilizing Aquablation therapy. I used to sign up all of the other procedures, you name it. We used to do it. But we would have overnight call a lot of times. Why is my prostate hurting? Why am I still having dysuria? Why am I passing clots? When is this going to get better? Where did my ejaculate go? When we started introducing aquablation therapy, our call volume went down about 80%. So patients were doing extremely well post-operatively with aquablation, and they've continued to do well. We have to undo generations of fear. Today's BPH treatment is not your grandfather's. I don't know how many times y'all have had this, but I'll have patients that'll come into me and be like, you ain't touching my prostate. My buddy Mark had that done, and he was never able to walk again. And I'm like, all right, well, what do you have done? He's like, I don't know, but it was to his prostate. I'm like, all right, man, there's like 15 things you can do to the prostate. So there's newer technology out there. Let's get assessed, and hopefully you won't have the same experience that your buddy Mark had. So these are pictures of my cystoscopies. So whenever I'm scoping the patient and I'm having the patient actually look at the screen and looking at these things, you can see how this would resonate with the patient. Even patients that don't know what healthy tissue looks like can look at these screens and say, okay, that doesn't look like what I would feel like it should look like. And I will actually show them pictures of healthy bladders post-procedurally, and we'll compare it. So, that would be a grade 3 trabeculation on the left, grade 2 in the middle, and that's a big juicy median lobe on the right. So these are my wall boards that I actually utilize to educate my patients. That's the trifold from the aquablation. So anytime I do a workup and I finish up with the patient, I give them the trifold of the aquablation. On these wall boards, I will actually draw the trabeculations in the bladder. I will draw the urine left over in the bladder. I will draw the aquajet removing it. And I do this with all of my procedures. I'll do it with the urolift. I'll draw the clips opening up the prostate. If it's a TURP, I'll draw those kinds of things. All of those things, I will utilize these wall boards because I want the patient to actually understand what's going to be happening. We don't have these in the satellite clinic, so I'm literally turning their IPSS score over and drawing on their IPSS score. I need them to visualize why they're having the issues, and then they can move forward with a procedure that can really help them out. What is recovery like after aquablation? So we started really heavily doing aquas late 2022. So we have, 2.5 years of experience with aquablation. This was not exactly how it was in the very beginning. It took us a while to get to these metrics. So potential overnight stay, 90% are going home same day, 1 to 2 days on a catheter, typically done on a Tuesday, and catheters out before the weekend. Avoid strenuous activities and sexual intercourse for a week. How soon will symptoms improve? 2 weeks to 3 months. So I say that the prostatic tissue has remodeling. You may pass blood clots, scabs over 3 months. So one of my patient complaints for aqua is intermittent dysuria. So every 10th or 12th pee, they will just have a really sharp burn. And what I tell them is they're actually passing blood clots, microclots, and scabs. Will they keep their sexual function? I compare everything to the other bigger resection procedures. So there's a reason why they're choosing aqua, and it's really to have the less risk about ejaculatory dysfunction, the least risk of ED, and then the least risk of stress urinary incontinence. I can confidently say I have had goose egg, 0 patients have stress urinary incontinence. I've had 1 patient complain to me that he had a decrease in ejaculate, and we do shim scores for the erections before and after these procedures, and I've had nobody complain of erectile problems after their aquablation. You will need another surgery at a later date. The prostate will continue to grow. The 5-year data for aquablation was fantastic at a 1% retreatment rate. 10-year data is coming out in 2027, so we're going to have hard numbers coming out here soon. But I usually tell my patients, treat this as either a 5 to 10 year longevity of the efficacy of aquablation, and hopefully they get longer. Can I stop taking their medications? Yes. The whole point of this is to get you off of your meds. So stay on your alpha blockers for about 4 weeks. The finasteride has been gone for a while, and then they can stop their alpha blockers. And then they always ask about the catheter, and I say the catheter is really just to keep that prostatic bed open and healed for about 24 to 48 hours and pass any kind of clots or crud that's coming through the bladder. And I compare it to a cast of a broken arm. All about post-op. So the more education you do pre-op, the better your post-op experiences will be. So I talk to them about their hematuria. I kind of joke. I'm like, you could pass a toy car through that catheter bag. And as long as that catheter bag is draining and you're not having abdominal pain, I am happy. And I will tell my patients, send a picture on your portal. We have Athena, so I'm getting pictures from my patients at all times. So I'll get pictures of like a worm, clot coming through the bag. I'm like, that's fine as long as you're draining. I have the hematuria scale on my pre and post-op education material. So in my post-op education material, it talks about all the things that could happen, and when you could call me, when you should call me, what to expect, the healing process, etc. So education to these patients, they want to know what's going on with them and when to worry. So these are my pre and post-op education materials. So again, it goes over the medications, what the medications are used for, catheter complications and how to write those, what to avoid, all of the things. So this was my 2024 data, and I know this because I actually pulled all this data and I went through every one of these patients' charts. So a 72% average decrease in the IPSS score, and 87% of our 96 patients we treated in 2024 remained off of their medications. To give you a comparable comparison scale, average decrease in the IPSS score for dual therapy, saying alpha blockers and your 5-alpha reductase, is a 10-point reduction. So if you're doing singularity therapy, it's like 6 to 8 points with alpha blockers. You add 3 to 4 points with your 5-alpha. If you have an IPSS score of a 30 and you drop the 30 to a 20, you're not doing that patient justice. You need a bigger gun to resect this prostate. So impact of streamlined workflow, a clear BPH protocol, faster appointment scheduling, utilizing the APPs versus a 6 to 8 week long wait. Our team is spent where it's most needed, educating these patients. It helps prevent burnout. My APPs are some of the happiest APPs I've ever seen. Increased ownership of the whole practice and patient care. You really feel like you are not just a cog in this wheel. You feel like you are making and creating outcomes. And zero adverse events since implementation. So my recommendations to the audience, especially if you're in urology, get in there and see a cystoscopy, see a transrectal ultrasound, see an aquablation therapy case. Educate the entire office on aquablation therapy. And this is the front staff to the medical assistants to the surgery schedulers. Everyone needs to know if a patient calls and say, hey, do y'all offer this water gun technique, that they're talking about aquablation. And, some of my most proud moments are, seeing my medical assistants see a PVR go from 200 to 50 and knowing why that's happening. Meet with your surgeon to discuss your patient care pathway goals and evaluate your patient education process. Talk to your patients about the side effects of medications and educate the patients on bladder health and irreversible damage. Utilize your data. It is so important. Utilize those IPSS scores. Utilize those PVRs. You have to have some subjective data to see if you're treating these patients right. So that's kind of my spiel on aquablation therapy. I really appreciate you, Vic, for having me on and let me talk to the audience about aquablation. It has been a giant success for my practice. I've had some of the happiest patients. I've had patients that have actually come to me and said, Alex, I would love to do a testimonial. Why do more patients not know about this? I have never had that for any other surgeries. And I've had actual patients high five me and hug me after this. And I've never had that for a circumcision. I've never had that from a prostatectomy. So obviously they're doing something right here. And it's been a really giant success for us.
Yeah, that's great. You can actually turn off your screen share if you want and get to the regular signs. I'm going to go right to the comments. We've had some really good ones here. I think one of these is a patient who was chiming in, which probably kind of supports what you had said. Just had aquablation on November 6th after suffering BPH for 15 years. I'm ecstatic with the results. My only regret was not doing it sooner. If you have a doctor he doesn't discuss, I don't know, they probably ran out of room there. But yeah, it's kind of testimonial. And we had another one. Aquablation. Oh, he's finishing it up with you. Get another opinion. Best thing I have ever done. Feel 40 years younger. And he did
that's
also
so great.
The procedure of recovery was a breeze. So, early on, I said that we had somebody talking about aquablation. And one of the things that I, kind of heard was that because the practitioners were so new into this field, that there was a lot of bleeding issues afterwards. Now I noticed when you were discussing where you did the slide show there, or the video show about the procedure, them talking about sealing the bladder neck. Is that something that's new to the procedure? Because I don't remember.
Yeah. So earlier on, Vic, thanks for the question. They weren't doing focal bladder neck cautery. So earlier on, when this was really introduced in 2017, it was a heavy bleeding procedure. And that's honestly why we didn't start doing it until 2022, because they had some kinks they had to try to figure out. So that's where they introduced the focal bladder neck cautery. So basically the Aquajet removes the obstruction tissue. And then after the Aquajet does all of its work, they take a loop wire and they really just cauterize the vessels at the bladder neck. So it's decreased the bleeding tremendously.
Yeah, that makes a lot of sense, because that was the issue that I had heard. As far as prostate size, you said kind of 50 and above is the Aquablation. Is there an actual ceiling on, are you doing 100-gram prostates or?
Yeah. So 30. So Medicare guidelines. And now again, I'm from Texas. So my Medicare guidelines from Texas is 30 to 150. Now that's Medicare. So private insurers will actually go up even higher. So the biggest prostate gland that we've done successfully is 220.
Wow. Yeah. That's kind of replacing robotic, simple prostatectomy.
It is. Now, again, everyone is going to have their opinion there for sure. I'd say the sweet spot for Aquablation, if you kind of wanted to do an umbrella term, is around 50 to 150 is really what they say.
Gotcha. Let's see. A few more comments coming in. Katie Bertel, what is the downside of this procedure?
I mean, if you're going to really ask downsides, I mean, you do have to go under anesthesia. I mean, that's one downside. You do have to do that versus an office-based procedure. There are risks with the procedure. Anytime you're going under anesthesia, there are those risks that kind of come along with it, like obviously the real scary ones about going under anesthesia. But stricture disease, there's always a risk. But what I always compare it to, and I compare it to all of my other procedures, it's less risky compared to your TURPs, compared to your HOLEPs, compared to all of those things. So like the big things that you worry about in terms of BPH procedures are stress urinary incontinence, erection issues, ejaculatory dysfunction. And then there's, the risk of, stricture disease. In terms of Aqua, it knocks those all out of the water. No pun intended, knocks them out of the water. So there's not a lot of risk. We up to date now, we've done, I think, 230 of these procedures. And I can confidently say that all my patients are doing extremely well. I think we have had to go back in on a stricture patient, 1 out of those 230. And I can't tell you how many times we were having to do that with some of the other procedures out there. Yeah.
Speaking of water, so one of the concerns when you did a TURP back in the day was water absorbing, kind of diluting down your sodium. Any issues with that?
Not at all. No, they figured that one out. But yeah, there's no issues with that at all.
All right, good. I've got another question that came in here from King Wang. Do we have to do a urodynamic study before this procedure?
You do not. You do have to do it again. Texas guidelines, you do have to have a urine flow measurement. So you can do that again with, Proud P. You can do that with UroCuff. You can do that with urine flow. You do not have to do urodynamics. So you do have to have a urine flow measurement of less than 15 mils per second due to Medicare guidelines.
15, you said?
15, 1-5, yeah.
Yeah. Okay. All right. Very good. So the workup is fairly simple. I liked a couple of the things that you had spoke about. Number one, patients are afraid of cystoscopy. They're afraid of prostate prostate measurement, ultrasound. I think if you can kind of take that fear away, it makes a big difference. I liked your video. I think I'm going to borrow it for my Uro patient on what happens for an evaluation.
Yeah, for sure.
Because, a lot of patients, that's one of their first steps of apprehension is even getting in the office. And, we're guys, I kind of try to avoid the doctor at all costs. This is an ambulance. So and a lot of men are that way. So I think that it's kind of worthwhile to
and that was
video
the interesting
kind of calm people down.
Yeah, that was the interesting thing, Vic. So like, when Procept really got interested in me and how I speak to my patients and my surgical conversion rates, they asked me, they were like, so what do you think your surgery conversion rate is? And I said 20%. And their jaws kind of hit the floor. They were like, do you realize that that's, 5 times the national average? And I didn't know what I was saying. So I thought I was a huge liar. So that's what actually triggered me to go look at all my 2024 data. And that's where I pulled all my cysto trust. Because, because I was the only provider doing cystoscopy and transrectal ultrasound. So if I pulled all of the alfuzosin refills or tamsulosin or other, you would just have too many patients. So I pulled all my cysto trust data. And that's where I found out that it was closer to 50% were actually moving forward with surgery versus 20%. So that's where I started changing how I speak to the clinics about aquablation. Instead of really trying to convince the APPs to start doing diagnostic cystotrusses, it's really just about getting the patient to the cystotrus. Because once they've kind of hit that precipice, moving forward with surgery, they've done the hard part, right? They've done the awake part. They've done the part where they're like, all right, let's get the evaluation. And now it's just like moving forward with going for the surgery. So I really think that is really the biggest take home about getting patients to the cystoscopy and transrectal ultrasound.
Mm-hmm. Yeah, absolutely. And we do have a follow-up question from King Wang. Even with diabetes mellitus or spinal issue patients, no urodynamic necessary.
It'll depend on your PVR. And so like if you were my patient and you were emptying well and, all of those things look good and all of your prostate size was good for aquablation, I don't need to do urodynamics. Now, if I bring you in and your IPSS score is a 20 and you have a PVR of 1,000, yeah, you're going to go do urodynamics. Yeah. So that's what I mean by using your tools. And that's why our patient selection is so good at our practice, because I utilize all that stuff beforehand. So I would catch you with really bad retention before this happened. So if you had a prostate size of 20 grams and you have a PVR of 500, then aquablation may not be your answer. Right. So you have to assess the patient, assess the whole thing. But yeah, for select patients where they have a blown out bladder, I'm going to have them do urodynamics.
Right. And you can kind of get an idea of what patients are going to be, somebody with a hypotonic bladder, just from, like you said, the history. They come in, they walked in, they didn't even know they had 1,000 cc's in their bladder. They've denervated their, desensated their bladder. So those are the ones you would want to watch out. So I guess we got your final answer. Thanks from
You're welcome.
Squang. So, all right. It's been really a great thing. We're kind of getting to the end here. So I'm going to bring in a advertisement for next week's show.
Micro-hole zone technology is changing the game in catheter performance, patient comfort, and clinical outcomes. In this episode of UroNurse, host Vic Senese is joined by Jessica Kenny, marketing specialist at Coloplast. She will break down the newest advances in micro-hole zone design and what the latest coding updates mean for clinicians, reimbursement teams, and patient care. Join us on December 13th at 9 a.m. Central Time to learn more.
So yeah, that's going to be interesting to kind of learn some of these new changes in the codings for coding, meaning for us to code for billing purposes, and this new technology in catheters. Whoever thought an intermittent catheter could change so much, but they really progressed over time. So it'd be interesting for those folks who didn't wait too long to get something done. Right. Now you're going to be strapped down with a catheter. I always say intermittent catheterization is much better than wearing a long-term indwelling catheter.
Mm-hmm. Yes, sir.
So, all right. Well, it's been really great. I've got a bunch of people saying how great your talk was. So I just thought I'd pass that along. But I'm glad you could join us again. It's always a pleasure having you on the show. And Alex, hopefully we'll get you on another show again in the future.
All right, Vic. Really appreciate it. Thanks for listening, everybody.
All right. Have a good rest of your rest of your day and rest of your week.
So here's to the mornings, the coffee, the monitor glow, to the wisdom he shares and the folks that he knows. Saturday is special when stream.